Good afternoon and welcome to today's IAC webinar, Advancing Staff Experience in Cardiac EP. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many as possible during the Q&A period. Also on the left sidebar, please note the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASRT CE credit, you must be registered, logged into this webinar, then complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and CCI. We are joined today by our guest presenters, our moderator, Dr. Walid Saliba, and 4 panelists, Geordie Baker, Dr. Thabet Alsheikh, Amy Leiserowitz, and Nate Manning. And now to introduce today's moderator, Dr. Walid Saliba. Dr. Saliba is staff cardiologist in the section of Cardiac Electrophysiology and Pacing in the Department of Cardiovascular Medicine at Cleveland Clinic, medical director of the EP Lab, and director of the Atrial Fibrillation Center. He serves as president of the IAC Cardiac Electrophysiology Board of Directors, representing FHRS, and he will introduce the first of our 4 panelist presenters. And with that said, I will now turn this webinar over to Dr. Saliba. Doctor?
Thank you very much, Kelly, for the introduction. Again, good morning, and actually for some of us, good afternoon, and welcome to today's IAC live webinar. I would like to thank you for taking the time to be with us today. We will be talking, more importantly, actually discussing issues related to advancing staff experience in cardiac electrophysiology. We are fortunate to have with us a group of experts who are willing to share their own experience with us. We will hear about the importance of having uniform training for our staff, uniform standardized processes with built-in flexibility, and how does this help improve quality, and more importantly, how do we monitor it going forward? So without further ado, I would like to introduce our first speaker, Geordie Baker. He's an EP technologist in Seattle, Washington, and he will talk to us about EP training post-pandemic lessons learned. Geordie?
Hello, my name is Geordie Baker, and I am an EP specialist in Seattle, Washington. I want to thank IAC and CCI for inviting me to share some of my thoughts with you. I also want to thank my fellow panelists and Dr. Saliba for moderating this discussion. My only disclosure is that I am a volunteer on the RCES test writing committee. My time today will be spent discussing some of the lessons I've learned over the last few years regarding EP certification and training. Today's talk will discuss the current state of EP certification, ongoing challenges that I've seen, particularly impacting management. Next, I will share a survey that I conducted, and I'll conclude with my own recommendations. So I think it's very helpful to know where a person comes from in order to understand their logic. So I want to briefly share my history in healthcare. I've been working in healthcare for 21 years. Started off as a CNA, worked as a medical assistant, and then had a career in EMS. I've been an advanced life support provider for 18 years, and I've been studying and teaching EKGs for about the last 18 years. And for the last 13 years, I've been working as an EP specialist, both as a technologist and as a supervisor. One of my favorite aspects of EP is that everyone has a unique story as to how they arrived to the EP field. While this might be a review for most people here, I want to review what I'm referring to when I say EP certification. So the current credentials, these are all specific to EP. I know there are many more specialty certifications that can be found in our industry. From CCI, we have the registry level RCES and RCIS. The certification level, the CCT and the CRAT. Through the IBHRE, we have the CEPS for electrophysiology and the 2 device certifications, CCDS and the new CDRMS for remote monitoring. And the ART also has EP content as part of their CI endorsement. So I'm hoping I'm not excluding any certifications, but please let me know if I have. So currently on the left side, we have self-reported professions of RCES holders. 69 report as being a CBT, while 21 report as being a nurse. On the right, we have a graph that shows 67% of respondents report getting their cardiovascular training from a school, while almost a quarter received on-the-job training. This demonstrates, to me, not only a need for more schools, but perhaps more importantly, the need for more onboarding and orientation. There's currently about 2,400 labs performing EP or EP-related procedures, and we just crossed the 1,000 RCES holder mark, which we're very proud of. And about a third of those RCES holders also have the RCIS invasive exam or credential. There's been this recent collaboration between CCI and IBHRE with the goal of making EP certification less ambiguous. Here we see the first 2 steps that represent the initial learning that staff experience as they acquire the knowledge, skills, and abilities to be successful in EP. The third of this blue step is the standard for staff, and that's the RCES certification from CCI. And finally, those desiring for more advanced knowledge can earn one of the certifications from IBHRE, such as a CEPS. The continuum helps change kind of the dichotomous either-or paradigm and creates a more linear progression as staff learn and grow in their careers. I want to take a few minutes to share some of the challenges I've seen regarding training and education. And I think I can speak for many of us when I say that staffing continues to be one of the primary issues EP leadership struggle with. Plug and play staff can be hard to come across, but we know where they don't come from. They are not delivered by the local stork, and they do not grow on trees. Do you remember playing Trivial Pursuit? And in order to win, you needed to collect all 6 different but equally important pieces of these little pies. I think assembling an EP team works very similar and very much the same way. When the leaders are able to draw from a wider net, so to speak. On this little floor on the right side, we have all the different backgrounds and training and certification that all kind of comes together to make an EP staff, from nursing and EMS, academia and the engineering world, and our radiographers and on-the-job training. There's so many people who come together to help make that team. And although many organizations are limited due to state laws, finding these applicants with diverse backgrounds really enriches the team. As the old adage goes, variety is the spice of life. Many managers experience this ongoing cycle between recruiting staff and then training staff, and then how do you retain the staff once they've been trained. So I sent out a survey to a group of people, asking them a few questions about EP training and orientation. I figured that might at least address the training part of that cycle. So I've seen this common scenario played out time and time again, and the scenario is as follows. You don't have any EP staff, travelers are so expensive, and you need to cross-train. The question is, how long should EP staff orientation be? The answer most frequently that I have heard, days, weeks, months, who knows? A common mistake from leadership is that they may not have a good understanding of the field or the content, or they don't know the right questions to ask. So training and education go untouched. So I sent out a survey to EP industry leaders. These leaders are from a variety of roles: hospital educators, EP lab educators, and folks working in higher education. They come from a variety of background. Some of them were in nursing, some cardiovascular technology, some radiology. And I presented them with a few different scenarios and asked for their input. So these were the three scenarios that I posed to them. Scenario one, cath lab tech with 2 to 3 years of experience in the cath lab, scrubbing and monitoring with little to no EP experience. Second scenario is a healthcare provider, whether it's a nurse or a paramedic, et cetera, with little to no invasive cardiology experience. And finally, an industry rep with EP experience, but they have little or no patient care or healthcare experience other than working in industry. So for the cath lab techs with the 2 to 3 years, the recommended orientation process was 4 to 6 months. For the healthcare provider with the little to no invasive cardiovascular or cardiology experience, orientation process was 9 to 12 months. For the industry rep with EP experience with little to no patient experience, orientation was 6 to 12 months. And so these are my recommendations for leadership in hospital labs. The five things that I have recommended. Number one, having an EP lab educator, whether it's a dedicated educator or a staff member, but at least someone who can create education plans. 2, having an education fund for more than school, but for conferences, books for the unit, certifications, et cetera. 3, a clinical ladder, if your organization allows, such as EP Staff 1, EP Staff 2, et cetera. And 4, real-time encouragement when staff learn something new or if they pass a certification exam. And finally, understanding the true costs, not just as far as salaries and attrition, but also in missed opportunities. For staff working in EP, my recommendations: learn your resources. Most importantly, whether it's in your organization, whether it's in your state, but also online. Learn about your scope of practice in your state and in other states. Getting involved with the Alliance of Cardiovascular Professionals or Society of Cardiovascular Educators. Plenty of ways to get involved. There's EP conferences that are virtual and complimentary. These are just 2 that have happened in the last month. Reaching out to mentors in the industry. And finally, most importantly, get certified. You'll feel that incredible sense of accomplishment when you pass. So I just want to wrap up my talk in 4 points. Education plans are critical to success. Certification is a win-win for everyone. Resources exist and they are bountiful, and lifelong learning results in mastery. Remember, Rome was not built in a day. And I just want to close with this comment that I heard from a leader, that they were not able to invest more time into training due to anticipated attrition. And I can find 2 red flags in this statement. We have to do so much more for our colleagues and patients. Again, thank you to IAC and CCI for hosting this webinar. Feel free to reach out to me on email or LinkedIn. Thank you. And our next speaker is Dr. Thabet Alsheikh, an electrophysiologist and the chair of the Heart and Vascular Institute at Baptist Hospital in Pensacola, Florida. Dr. Alsheikh.
All right. Good morning. Good afternoon, everyone. Geordie, thank you for this introduction and for this great presentation. I think I want to also thank everyone who made this webinar possible and all participants, and for giving me the opportunity to share our story. And I think Geordie will be happy to see that we've been following your recommendations. So let's get started. The webinar objectives are many, and I thought the best way to touch on all of them in 10 minutes is to share our story, and hopefully in a way that will be helpful to everyone. Let me give you an idea about the facility where we work. Our hospital, Baptist Hospital, is about 250-bed community hospital in Pensacola, Florida. And this is actually what the new hospital that we will be moving to next year looks like. We have 3 EP labs and 6 electrophysiologists. 2 of them joined us in March of this year. Our current number of EP staff is 15. All of them are RCES certified, and we are IAC accredited facility. If we agree on these 3 points, I believe we will not hesitate spending all the time, energy, and money needed to build a stronger EP team. Number 1, staff experience and skills are as important as the physicians for determining patients' care and outcome. Number 2, physicians' training is standardized while staff training is not, just like Geordie mentioned. We all have the vested interest in having well-trained staff. Like every story, our story has a beginning, and ours started about 8 years ago when a newly hired VP for cardiovascular services required that all EP and cath lab staff be RCES or RCIS certified within 18 months in order to remain employed. I vividly remember how unhappy and worried the staff were. Few have not even heard about RCES or RCIS. Some felt the goal would be an impossible one and they better start looking for a new job. The goal was well defined, but we had to work through finding and committing the means to achieving that goal. After a few discussions and one meeting the EP physicians had with the staff, we agreed that the physicians would commit to bi-weekly 6:30 a.m. didactic lectures and weekend review sessions that usually takes about 3 to 4 hours. And the staff would commit to group review sessions and to self-study, in addition to the ongoing on-the-job learning and teaching. To the best of my recollection, the didactic sessions started in 2016. I was able to find these 2 flyers from 2019 as an evidence of what we did. You can see the announcement here every first and third Wednesday of each month at 6:30 a.m. You can see IBHRE mentioned on both flyers because by then everybody was RCES certified and we were working towards IBHRE certification. This is discussing WPW topic, and you can see at the bottom of the flyer here, study, study, study. Everybody was encouraged to study. So how did we do? After 15 to 18 months of didactic sessions and focused efforts on everyone's part, all staff members passed RCES exam one after another. Of course, the brave, confident ones started first and provided feedback and encouragement to the others that followed. Everyone passed after the first attempt. The exam fees were paid for by the hospital, and everyone received a raise after becoming RCES certified. The 12 to 18 months of teaching and learning and working together towards common goal did not only achieve that goal of getting all staff certified, but also ended up being amazing team building activity. I recall buying a cake for the first team member who passed the RCES, and that one suggested to buy the cake for the next one who passes the test, and so on. These are the few pictures I could find for those cakes celebrating those moments. Michelle ended up being certified in both RCES and RCIS. This is my favorite cake. Chris, RCIS, not just a nurse. The team felt so proud and so strong, and the list of names of staff who are certified was displayed on a plaque in the main hospital hallway for all to see. This is Jason. He's actually a current team leader, proud to point to his name that was just added to the list at the time, and he sent us this card. To Dr. Alsheikh and all the CAS EP crew, thank you for investing in our success. Couldn't have done it without you. The whole hospital acknowledged and celebrated the new team with a lot of pride. Some of the staff went to pass IBHRE as well, which, as Geordie just mentioned, is the highest level of proficiency for allied professionals. I also received this framed picture that I display in my office. To Dr. Alsheikh, an appreciation of your support, encouragement, patience, and guidance on our journey towards becoming the best EP lab, with thanks from your staff. It is true that being the best you could be is a journey and not just a simple step. Everyone felt competent and valuable. One day I come back to find this written on the board by one of the nurses. By now, we not only build a team, but we also build a strong image for that team. Everyone loved that statement. And as a result, we actually now, at the end of every timeout, except when Frank and IAC were checking for reaccreditation, I say, who is the best EP team? And everyone in the room would answer, we are. Last week, I told the team that we should record how we do our timeout for the purpose of this talk. And just past Monday, I received a video, the following video I'm going to show you on the next slide, from one of our CRNA who took the time over the weekend to personally making those t-shirts for the team to wear and to display what our timeout looked like at the end of the official timeout. I hope you can hear it.
So at Baptist Hospital, every timeout, we say,
it's good to think highly of yourself, but it's even better if others share that view. Our EP lab was put on the map as one of the first 8 in the nation to get IAC accreditation in all areas of EP, ablation, device implantation, and chronic bleed management. Of course, we made sure that few of our staff go to HRS to be recognized for that honor. We were invited to be the spotlight for EP Digest in 2018, and everyone was included in that article that was actually written by the manager of the cath and EP lab. A year later, we were asked to share our experience with same-day discharges after AFib ablations, and once again, we made sure to include the team. And the same thing in a follow-up article in 2020. During COVID, we also took the time to educate our community with free monthly AFib webinars. The staff also participated, and those lectures are now on YouTube for all our patients and staff to watch and learn from. As a team, we always work to standardize procedures when possible and to keep a list of some preferences unique to every physician. We also track our performance and complications with monthly M&M. Although our complication rate remains way below national average, we found out a few years ago that the vascular complications comprised the majority of them. So we started using ultrasound to guide access and using closure devices to achieve hemostasis, and basically on almost all patients. As a result, we had 0 major vascular complication in 2020. This was also accepted for publication last year. How do we maintain the competency for our staff? We continue to have regular didactic lectures, although a little bit less frequent now. And we record those lectures and build our educational library through Zoom webinars recording, in addition to the former continuous education for our staff and on-the-job training. But staff, our core staff mentoring and onboarding of the new staff remains the key, basically, way of building education for the new hires. In healthcare, we continue to spend a lot of efforts and money trying hard to recruit and trying harder to retain. In our lab at Baptist Hospital, we worked long and hard to build a culture of growth, quality, teamwork, recognition, and distinction. As a result, we did not have to worry so much about recruitment and retention. Actually, we went through COVID without the need for travel nurses and independent contractors, and the existing staff always volunteered to work extra day a week until we recruited the staff we needed. There is no magic to it. Do what it takes to build a team, and the rest is easy. I thank you again, and I want to turn it over to Nate Manning.
Well, thank you, Dr. Alsheikh, and thanks to Kelly and Frank and IAC for having me. Except I won't thank you for, I have to follow Dr. Alsheikh's performance in Geordie. But other than that, I thank everyone, and it's really humbling and an honor to be part of this group. So thank you very much. So as said, my name is Nate Manning. I'm the EP specialist / coordinator up in St. Cloud, Minnesota, CentraCare Heart and Vascular Center. A couple of acknowledgements first. Jackie Brune, who resigned unfortunately in 2021, well known by IAC and basically our program and any success that I have, we owe to Jackie. She put us on the map, like I said, also well known to Frank and all of IAC. And also Dr. Ann Dunnigan, who we lost earlier this year, started at the University of Minnesota in 1983 in pediatric electrophysiology. I have the honor of calling her a dear friend. I had the privilege of working with her in the pediatric field for many, many years, and just a huge loss to the world of EP. So I wanted to give a shout out to my dear friend. So, CentraCare Heart and Vascular Center, I looked from our EP lab this morning, about 5 degrees when I came in. That's 2 of our EP labs and LifeLink in the background. So, advancing staff experience in cardiac EP. We're located about 50 miles northwest of the Twin Cities. Our first dedicated EP program was started over about 20 years ago with Dr. Milstein, and then Dr. Ann Dunnigan was on board for about a decade with our pediatric EP program. Currently, we have 5 electrophysiologists. Our section chief is Dr. John Schoenhart, and we have 5 electrophysiologists, dedicated EPs, 6 dedicated EP APPs. We're doing about 2,300 procedures a year, and in our pacemaker ICD clinic, we're managing about 4,500 clients a year. We have 3 dedicated EP labs, 5 dedicated EP RNs. We have 10 dedicated RCES and 5 dedicated EP RATEX. Average seniority on our staff is 11 years. And that's what I'll probably touch on the most, just how we managed to keep our staff, and especially now through COVID, people are still having emotional trauma and still need the attention and the care, and especially at a local level, meaning the EP program itself. We are the only IAC program in Minnesota, and recently 2022 U.S. News and World Report, number 30 U.S. cardiac program. Our philosophies, I started back with Dr. Milstein, and Dr. Milstein, from the very beginning, stressed that the EP lab is the center of the entire EP program. And when the EP lab is doing well, the entire EP program does well. He was always promoted open lab to promote team and collaboration. So when you see a typical EP lab, the workroom is closed off, and we design our rooms for the workroom to be open. That way, just promoting more open culture if there are issues during the timeout. So he always promoted that. Dr. Schoenhardt now, as our section chief, promotes the same thing. You know, we're all a family, and as Dr. Alsheikh, I thought, demonstrated so well, the total success of the EP program is just 100% a committed EP chief provider, part of the team, and I just thought that Dr. Alsheikh demonstrated that exceptionally well. And then from my standpoint, a lot like Geordie, I have a mostly EMS background. When we get industry in, I often hear that they're impressed that I am a working manager, but they don't always see that. And I firmly believe that, you know, as a working manager, I'm not going to tell anybody to do anything I wouldn't do. I think there's a credibility issue, knowing that I could be in a difficult case, I can manage a difficult case, and that trickles across the team. And then with my flight background, also I learned from a very young age at 20 or 21, was as a paramedic, that the pilot RN and paramedic are all equal, and that's the way we function in our lab. The electrophysiologists, the nurses, the techs, we're all on the same ground, and if somebody is not doing their job, then we have negative patient outcomes. And also the flight, we were CAMPS accredited, so it gave me the appreciation of accreditation at a very young age. And we can say we're great all we want, but what I love about IAC and accreditation is when we get challenged, we can present them with here IAC says we are doing things well. And then also what I preach and what I also learned from the flight background is our customers are every person that you encounter during the day while you're in the hospital. So if it's somebody trying to find their way, anyone that we run into is our customer. As far as our education, we're lucky enough to in Minnesota to have 470 medical device establishments, first in medical device patents per capita in Minnesota, which provides us with education opportunities, live heart labs, things like that. We do require RCES within 3 years of hire. Interestingly, that Dr. Alsheikh touched on the difficulty when that was announced. As he said, we had people that were going to resign, met with hesitance, and also like what you said now that we have 10. We have a RCES Wall of Fame. We put their plaques up in the EP Hall, and it, as he touched on, it's just they just are very proud of it. And then also, one of our retired cardiologists made a education fund that we use for EP literature, scientific sessions, FHRS, RCES, and CEPS, and that will pay for all of the testing. And then when we get new staff, this is the literature that we give everyone when they come in, and then we will study with them. So with that, again, it's an absolute honor humbling to be a part of this, and I thank you. And up next is Amy Leiserowitz. She is the Technical Director of Arrhythmia Services at Iowa Heart Center. Thank you very much, and you're up.
Okay. Thank you, Nate, and thank you, IAC and CCI, for inviting me to participate in this presentation. And good afternoon to all who are listening here. I would like to focus my talk on the experience that I have had growing with the growth of the Heart Rhythm Center within Iowa Heart Center and the Device Clinic in particular. My disclosures are as follows. Device therapy used to be quite simple in the 1970s. In fact, the pacemakers were see-through. Only ventricular pacing was offered, and there was no programmer. In fact, you had to change the rate of the device with a needle placed into the patient's skin and into the device itself. They were non-rate responsive and implanted by general surgeons. I'm going to date myself a bit, but because I graduated from nursing school in 1977. Since that time, I've been a full-time cardiac nursing, and the past 36 years have been in the device clinic with Iowa Heart Center. When I joined Iowa Heart Center, then when called Cardiology Associates, the technologies of pacing and electrophysiology devices just had a very accelerated growth. The devices became programmable. Dual chamber pacemakers were introduced. Rate responsive pacemakers were used. And in fact, sometimes the implant of the new Medtronic's Activitrax in VVIR was quickly adapted and inappropriately used at sometimes, providing patients with pacemaker syndrome. ICDs were only by rate, oftentimes referred to as shock boxes. Then we saw patients with 2 implanted devices, one in each subclavicular area. And then the ICDs came out with pacemakers included to the present time. Remote monitoring was started in the 2000s, and biventricular devices were used for heart failure. Subcutaneous ICDs were used. Implantable loop recorders were inserted. Leadless pacemakers have been being used the last few years. And as of this year, cardiac contractility modulation devices for heart failure therapy have been started. Not only have we increased the length of life for patients with our implanted devices, but we have improved the quality of life for those patients. The growth of the EP department was very rapid. From no EP when I joined in 1985 to the present 9 electrophysiologists, 5 EP advanced practice providers, from 1 single nurse to 6 device nurses, which includes a remote nurse that does just remote monitoring, and 4 EP clinic RNs, which work with providers in the office and work on the inbox and the electronic medical record. A few years back, we developed an atrial fibrillation clinic in which 2 RNs work and a medical assistant to run the Watchman program. And presently we have over 500 Watchmans implanted. We went from a single device tech that would do basic technical things within the clinic to 4 dynamic arrhythmia techs who review life vest recordings, are champions in remote monitoring, and managing the websites of the remote monitors. And we also have our leader, Christine Greaves, our Director of EP Services for the Iowa Heart Center Clinic and the Mercy One Hospital. Departmental growth started back in 1989 when I attended the North American Society of Pacing and Electrophysiology, known as NASPE, meeting in Toronto. I took the NASPE exam at that time, which now is the IBHRE, and it was the first time it was open to allied health professionals. I was the clinic at that time, and I only followed 150 or so pacemaker patients. I did not know where I stood. At that meeting, I met lead scientists that said someday there will be a leadless pacemaker, and I thought to myself, not in my lifetime. Late in the 1990s, I focused my energies into being the technical director of the device clinic, developing protocols for standardization of processes within our department. Between 2000 and 2010, the EP clinic continued to grow. We had the privilege of hosting educational opportunities to other device clinic staff around the country and shared protocols for best practices. Not only did they learn from us, but we learned from them. And then from 2010 to the present, we continue to fine-tune our protocols and guidelines. And most recently, we've learned that we need to break down those guidelines into smaller parts. When you have a protocol that keeps being added and added to, it gets so many pages long that the nurses have a hard time going to it to find the information they need. So we're going to break it down into small parts. Example is like, what are the steps in deactivating the ICD therapies? You know, getting the order. What do we do with the remote follow-up? Those types of things. It's important to create resources which are easily accessible anywhere you practice within the organization. Iowa Heart Center has many offices across Iowa, and our network of computers have a network section especially developed for the EP department. Within that section, there's technical information for for each of the device manufacturers that we work with. There's patient teaching documents, procedure packets, which includes the EP order sheets for device implants or any EP procedures. There's also peri-procedural device management recommendation forms, and as well as MRI conditional CIED information and MRI device management recommendation forms. I don't know about you guys out there, but we may have faxed requests for device management recommendations up to 20 in a given day. And of course, in their network section, we have device advisory information, which goes through steps of what the advisory is and how the device needs to be followed and what the physicians have decided for our patients. Teaching new device RNs has become much more complicated as the devices become more complicated. The in-person training starts off with the RN being a mentor, the seasoned device RN being the mentor and having the new RN observe. After several days of observation, then the nurse being oriented will use the programmer to do the testing. And with that, a cheat sheet was formed to help with writing down the information that will be needed for the formal report. During the evaluations, clinical implications are discussed because, we're not treating the device, we're treating the patient and trying to create the appropriate settings for that patient with that device. Lastly, they learn how to write up the evaluation. We use standardized formats, which outline the different details for our charts, the mentor reviews, and checks off the different variety of devices that the new nurse has evaluated. And then electronically, the evaluation is sent to the provider for review and signature. Finally, the nurse gets billing privileges, which includes all the education on the service periods with the remote monitoring and such as that. Mentoring is always available for the new Device RN. A new Device RN does not go out to an outreach clinic for device follow-ups before a whole year of training within the office with a mentor. No mistakes, only learning opportunities, and that shows the need for clear guidelines. Here's an example of the device evaluation cheat sheet form. They're half sheets of paper with on front and back. It helps collate that information and points out what is important to include in the evaluation. So we need to set goals, and these are changing times. We need to map the way to success of the department. We need to add the certification testing to the job descriptions, and we have done so this past year. The staff need to be encouraged to advance their career and job status with the IBHRE, CDRMS, and CCDS, the CCI's CRAT, CRAT test for rhythm analysis. And I believe that the staff need to be rewarded for certification, as was shared earlier today. This certification provides a higher job level to those in the device therapy. We need to continue to work on retention of employees, and the facilities that employ staff really need to learn the importance of educating the staff and investing in the staff, such as supporting them to attend national educational programs such as the Heart Rhythm Scientific Sessions. Our EP labs here in Des Moines and West Des Moines have been accredited through IAC, and I had the privilege of working with IAC board of directors to create the standards for the device clinics. And this is a goal for our clinic in the future. In conclusion, anyone working in our field knows it's all in the details. Being detailed in this environment is a must. Standards spell out those details, and those standards can be found on the IAC website for EP labs and device clinics. I thank you for this time, and I'll pass it on to Frank.
Thank you, Amy. And at this time, we will begin the Q&A session. From IAC, I'd like to introduce Frank Vermeeren, IAC Director of Accreditation for Cardiac Electrophysiology. He will assist with the Q&A session today. Frank, would you like to start us off?
Thank you, Kelly, and thank you to everyone who's joined us today, and a special thanks to all the speakers. These discussions were excellent, and they really do stress the fact that technology and procedural techniques are not static, and it really stresses the importance of a structured training program and ongoing education. and probably more importantly, that there's great support within your institution and cheerleaders in your institution to help educate each other. We've had several great questions, and I'm going to pass the first one to Nate, because this one actually was specifically called out for him. It said, how long does a new staff member take to accomplish an RCES credentialing via your internal training? Do you have a hiring preference now for new hires, like RN, RT, EMT, et cetera?
Yeah, great question. So, actually, the last EP tech we hired, actually very close with another candidate, and she actually did have RCES credentials, which bumped her ahead of the other candidate. When a candidate starts, we give 3 years, and I know that some may challenge that. Well, how do you even know if they're going to be employed in 3 years? But it seems we just do not want to pressure. We want to promote and not pressure. So, if you can get it done sooner, but that's kind of why I had it stretched out a little bit.
Thank you, Nate. The next question, I believe, is really pertinent for Amy to answer. And this was, they asked if anybody on the panel had taken the CRDMS credential exam from IBRG for device clinics.
I am actually the co-chair of the CDRMS test. Anyone that is doing device follow-up, I encourage them to study for it and take that. That is a less intense device test than the CCDS. It truly focuses on doing remote follow-up and not the reprogramming of the device. I personally do not know of anyone who's taken the test yet, but the hope is that several of our staff members will take it next year.
Great, thanks, Amy. And as many of you know, the CRDMS is a brand new credential by IBRG, and so it's really new for everyone, and they're doing a great job of getting educational information out for people to sit for the exam. So their website is excellent. It has great information and tells you exactly what you need to know to sit for the CRDMS or CRDMS. It's a lot of initials. And so please feel free to go to IBRG and look that up. And as this goes for CCI and ART, they have great resources and pathways for everybody to sit for those respective credentials. I'm going to put this question to Dr. Alsheikh. This individual said, how did you get buy-in to allocate time and resources for the EP staff education with your administration and management? Do you have points of focus or strategy to bring awareness to hospital administration of the importance of continual education and competency evaluation?
Thank you for the question. These things, no one has time to do anything extra or even essential with our busy lives and the different responsibilities. But I found it very rewarding once you start anything with real, genuine interest to make a difference for somebody else. It's amazing the feedback and the energy you get back from the little victories and wins you achieve along the line. And I was just able to dig through some of the pictures I shared with you, and I think I hope I made my points clear. The hospital was all for everything we asked for, including paying for the test, giving them raises for recognition, not only for their achievement, but also financial recognition by giving them raises, allocating some funds to send them to conferences. The administration, sometimes you may disagree with them or with what they have in mind, but once they see the results, they can't argue much. So it is really not that hard once you start, and you'll be surprised by the feedback you receive from your staff and by the energy and the ideas they have to help you along the way. So I don't know if that answers the question, but it is hard, but at the same time made easy by the outcome that you find out.
Thank you, Dr. Alsheikh. This next question that we have actually is a general question, and it has to do with for individuals who are interested in becoming an EP tech or work in the EP lab. And the specific question was that if they had the background of a nuclear medicine or nuclear and cardiac technologist, where would that person even start to gain EP experience or EP information? And I think some of that information has been answered here, but I want to open that up to everyone. I want to reiterate one of the points prior speaker made was that there are several pathways for people to take. If you're a nurse, if you are an RT, have an RT background, if there's a pathway for everyone to get to the EP experience. Sometimes it's a little serpiginous, where you may have to get a credential, kind of do a bridge to get to that point, but there is a pathway. So I think that maybe Geordie's probably the best person to answer this question, since he has so much information on training pathways.
Yeah, Frank, as a professional already in medical imaging, this person is already on a great path. I'd start by doing two things. First, look into EP labs or clinics in your organization or city. Cold call people. That's how I found a home in a lab 13 years ago. If your hospital or organization that you work at has a lab, talk to the staff there and see if you can visit them and watch an ablation. You may discover A, that it's not for you and you're happy where you are, or B, and if you're like me, you'll watch a 3D mapping procedure and your mind will be blown. And your only question will be, how can I work here? Second, look into the laws in your area. See the current training, or see if your current training or certification allows you to work in EP. Having a background in nuclear medicine might already be a radiographer, so it may be an easy transition. If not, what would it take to you to get that job in EP? As Frank said, maybe you need to get just an additional endorsement or certification. It does vary pretty drastically from state to state and even from hospital systems within the same city. So find out where you stand in that kind of messy understanding of licensure and certification, and then go from there.
Great, thank you, Geordie. And that was our last question for today. So I'm going to hand this back over to Kelly, and she'll give you additional information on how to get your credits.
Okay, thanks, Frank. And thanks again, everyone. And a very special thank you to our guest presenters for their presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars, look for the title of this session, Advancing Staff Experience in Cardiac EP. Beneath this title, you will click Review Event. On the left, select the Evaluations tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen, and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.